Hi everyone. We'll get started shortly. I'll just give everyone a bit of a chance to come in through the Zoom link because it can take a little bit of time, and we'll get started then.
Judith.
I'll get started now. Hi everyone. Erica, I'm the National Nurse Manager and one of the nurses here at Lymphoma Australia. Some of you may have been to one of our webinars previously, so thanks for joining us again, and welcome to those who are new to Lymphoma Australia. I'd like to begin by acknowledging the traditional owners of the land. I would like to pay my respects to elders past, present and emerging. I'll start with some quick housekeeping as well too. If you've got any questions throughout the webinar, pop them in the Q&A function at the bottom of your screen. You don't have to wait until the end of the session. You can pop them in as you're going as well too. And if we've answered the questions throughout the session, we'll skip it and move on. So don't hesitate and just pop the questions in straight away when you think of them. We do have time allocated at the end of the session to get to all of your questions as well too. So there is a chat function down the bottom of your screen, but it's not going to be monitored. So just make sure that you do actually use the Q&A function. If you miss anything as well too, or you want to listen to the session again, because there is a lot of information being presented, we will upload it to our YouTube and Spotify within the next few days as well too. We'll also send you out the Zoom recording link, so you'll get that. Just for anyone who isn't aware as well too, Lymphoma Australia actually hold online support groups and some in-person sessions too. We have quite a few scheduled sessions over the next month or two as well. So if you want to get any of the information about different session times, or if there's any in-person support groups in your area, you can find all of the information on our events calendar as well too, how you registered for this. So it's on the homepage of the website and you can see it. I will pop the link to our events calendar in the chat as well. So if you did want to click on it at any point in time, you can see it there. If you've got something specific that you'd like us to organise, please reach out to us. We're happy to hear your suggestions or anything that you think that is a bit of an area of need around your education or some support services that you wanted to know about. Let us know. At the end of the webinar, there's also a really quick survey, and we really appreciate it if you take the time to complete it as it helps us with our planning going forwards as well. So on today's webinar, we have two speakers. Firstly, I'd like to welcome Dr. Ibrahim Tohidi Esfahani, who is a clinician researcher at Concord Hospital in Sydney and is a co-principal investigator in the WM study Whimsical. Whimsical is a novel research partnership between clinicians and patients and is now an established platform for patient-driven research, capturing patient-reported treatment and quality of life outcomes. Dr. Judith Trotman, who is our other speaker, who will be joining us, is the head of the Haematology Unit at Concord Hospital in Sydney. Dr. Trotman is committed to embedding lymphoma research into world-class clinical care as the founding director of the Concord Hospital Haematology Clinical Research Unit. Her research is characterised by a commitment to focusing on current priorities for lymphoma patients. Specifically in WM, Dr. Trotman has had the privilege of being investigated in Innovate study, which was rituximab plus or minus ibrutinib in WM, and has also been heavily involved in the development of zanubrutinib for WM patients. Dr. Trotman implemented a prospective study characterised by an impaired antibody response and viral neutralization, but preserved COVID-specific T-cell responses to Pfizer vaccinations for WM patients treated with BTKIs or chemotherapy. So to get the session started, I will pass over to Ibrahim, who will be speaking, and Judith will jump in as needed. Thank you.
Thanks very much, Erica. I'm not sure if you can see me, but hello, everyone, and thanks for coming. And thanks to Lymphoma Australia for organising this and inviting us. So I'm going to be presenting most of the talk on the slides, and then we're going to have a Q&A session at the end where Judith and I will answer your questions. So this is a bit of an overview of Waldenstrom's, just to for those who are fairly new to it or who don't know too much about the condition. But we will get into some depth, particularly when it comes to the treatment side of things. And I do hope it doesn't go too much over your head, but feel free to ask questions later on. So let's get going. So what I want to cover today is what exactly is Waldenstrom's macroglobulinemia, and how can it present, with what symptoms, then what is used to diagnose the condition, and once it's diagnosed, when do we actually need to start treatment, and when we do have to start treatment, what can we use in the first line setting? What can we then use in subsequent settings if it has progressed after that treatment? And then some more important future-looking parts of the talk is how can we together drive Waldenstrom's research forward, and where exactly is Waldenstrom's research going? So quite a lot to get through, so bear with me. So starting with a definition for the condition. So Waldenstrom's macroglobulinemia is also known as lymphoplasmacytic lymphoma, which isn't any easier to say, but it's considered a low grade, which means it slowly develops and progresses, usually, and it's a non-Hodgkin's lymphoma. So it's a cancer of lymphatic cells. Now, what it actually means, and why the name is lymphoplasmacytic lymphoma, is that we have an infiltration of the bone marrow, which is your blood cell factory. It produces all the blood cells in the body. And it has infiltration by cells that are either like the lymphoid cells, which are the yellow arrows, which are nice and round, or plasma cells, which produce the IgM antibody, which is necessary for the diagnosis of Waldenstrom's, and cells in between, which are called lymphoplasmacytic cells. So that's the reason why it's got its name. And to define the condition is having this infiltration of these cells in the bone marrow, as well as a monoclonal, which means only one type, a single type of immunoglobulin M, or IgM paraprotein. And down the bottom on the right, I've put an example of different types of antibodies, which are immune proteins that are part of the system to recognize and destroy invading pathogens. Now, IgM is the one here with 5 different arms. And the fact that it's got 5 arms rather than just the one, like IgG, makes it a lot bigger, and therefore it can make your blood a lot more viscous. And you may have heard of the condition hyperviscosity as a result. Now, WM is very rare. Incidence, which means new diagnoses, incidence of only 3 per million people in the population each year. And that's based on American data. And so that makes it quite a rare cancer. Now, it typically affects people in their late 60s to early 70s, and it seems to affect men more than women. I just thought we'd include some pictures of what it looks like in the bone marrow. So what we're seeing here on the left is a picture of, when you have your bone marrow biopsy, as I imagine many of you have. This is a little piece of bone that they take out and they slice, and we look at the cells within it. And here on the left of this picture, we have lots of normal looking bone marrow. And then you've got this purple cluster in the middle, which is where all the Waldenstrom's is infiltrating. And then on the right with the brown colored pictures, we're just showing that they're marking positive for CD20, which marks the B lymphocytes, and IgM, which is critical to the recognition of the condition and the treatments for it. So as I said, it's a very rare condition, but it's important to know that you're not alone. It's important to know of these very amazing different groups. WM Aussies is the Waldenstrom specific Australian support group that's an affiliate of the International Waldenstrom's Macroglobulinemia Foundation. I strongly recommend, if you haven't already, looking at the iwmf.org website. It is a fountain of information geared at patients. It's very useful. Of course, the Lymphoma Australia and the Leukemia Foundation all provide amazing support and networks. Now, how does WM present? Up to a third of WM patients, when they're diagnosed, don't have any symptoms at all. But what the majority of you have experienced and do experience is fatigue. And this is driven by just the condition itself, the fact that the infiltration in the bone marrow can cause anemia, as well as that hyperviscosity I was talking about, which is that thickness and viscosity of the blood. Now, when this gets particularly bad, it needs urgent treatment, something called plasma exchange, plasmapheresis, but it can cause things that would give signs of hyperviscosity are headache, nosebleeds, blurred vision, being drowsy or confused. And on the right here, I've just included a picture of the back of the eye and the blood vessels, where that viscosity of the blood is causing rupturing of the blood vessels. The other things you can get are enlarged lymph nodes, something called B symptoms, which is a combination of fevers, particularly over 38 degrees, a weight loss of more than 10% over a 6-month period, and night sweats. Bleeding is also seen, particularly with, particularly from the nose. One thing I haven't put here is leg cramps is fairly common. And then neuropathy, which is caused by the IgM protein damaging the nerves, typically affects the hands and the feet in a glove and stocking distribution, where it's almost always a loss of sensation. There are other rarer forms that WM can present in. It can present with just kidney disease, which will be hard to pick up other than on routine blood tests or a urine sample. It can sometimes cause skin changes, but these are rare. And a picture of, it's not a high quality picture, but these purple, what we call papules or purpura can be seen. And then even rarer and more severe manifestations of Waldenstrom's are amyloidosis, where insoluble forms of protein due to the IgM form in organs and causing them to fail. And then if the lymphoma, if the WM cells infiltrate into the brain space, it's called Bing-Neill syndrome. So how do we diagnose WM now that we've suspected it? So the first thing that's most important is that your doctor asks you lots of questions about the different symptoms, whether you've had any cancers or lymphomas in the family. They need to do a good examination, looking for lymph glands, the size of the spleen and the liver, the function of the heart and the lungs. And there's a long list of blood tests, which I'm not going to go through here, but they're here for you to look at later if you like. And these are all very necessary in terms of determining how severe the condition is and how well your body is ready for treatments of different forms. But what's important to remember is what's your IgM level, what's your hemoglobin, and your ferritin, which is a marker of your iron stores in your body. Now, we typically recommend the necessary for diagnosis investigation bone marrow biopsy when the IgM goes above 10 or 10 grams per liter. If it's still not at 10 grams or more, but you're developing symptoms, that would be another time to check, to do a bone marrow biopsy to see if, to confirm the diagnosis and to get treatment underway if necessary. It also gives the opportunity to do special WM cancer gene mutation tests, which I'll go into a bit later. Now, sometimes you'll have a CT scan done from the top of the neck to the bottom of the pelvis. This will be especially done if there are big lymph nodes or organs seen on examination. You may have heard of a PET scan used in a lot of different lymphomas or other cancers. There isn't a role of PET scans in Waldenstrom's. And then there will be other targeted investigations based on the symptoms. And I thought I'd just include here that there's no role for testing your relatives for Waldenstrom's once you get diagnosed, because it's not something that's inherited, but it is seen in the family, which means that there is an increased risk of developing Waldenstrom's if you have a family member with it. Now, these special gene tests, which you may have seen in your readings, the most important one which, for diagnosis is the MYD88 gene mutation. When we say mutation, we're not talking about mutation in all the cells of your body, like in your DNA. We're just talking about in the DNA of the cancer cells. Now, this mutation is seen in more than 95%, in 95% of Waldenstrom's cases. And also there's a condition called monoclonal gammopathy of undetermined significance, or MGUS, where patient only has an IgM monoclonal protein, but no evidence of Waldenstrom's. So their bone marrow doesn't show any evidence and they have none of the symptoms. In that, about 50% or more of them have this mutation as well. And the ones that do are more likely to progress. So the only reason why this is really necessary is that if there's a bit of doubt about the diagnosis, and that can be the case because there are other lymphomas that can mimic Waldenstrom's. And then if for those where the diagnosis is clear, but they don't have this mutation, we know that they don't respond as well to ibrutinib or other, what we assume other Bruton tyrosine kinase inhibitors, but that's not proven yet. Another mutation you may have heard of is CXCR4. Currently, particularly in Australia, this doesn't have a major impact on how we would choose the treatment. And so it's not a critical test. It's only present in up to 40% of patients. And the main reason to do it would be in the context of a clinical trial, but it's also been associated with a more aggressive disease and resistance to ibrutinib. People still respond to ibrutinib, but it takes a bit longer to get their best response. And they sometimes become, they progress through ibrutinib a little bit quicker. There are other genomic tests that can be done, which are important in trying to predict, I guess, responses to treatment, but I won't go into depth into those. So when do we actually need to initiate treatment? So first thing to say is we don't need to rush. And the reason for that is many people, I guess something similar would be like prostate cancer, where a lot of patients who get diagnosed with prostate cancer, they live their life with normal life expectancy almost, but you know, they often die of other causes. And so it's important to remember that just because you have a diagnosis doesn't necessarily mean it needs treatment. And that's because it can exist for many years without causing any symptoms or any damage to the body. And because none of our treatments are cures at the moment and they all have toxicities, then one shouldn't rush into treating a condition that can be relatively benign for many, many years. Of course, once there is a paradigm shifting treatment that is curing Waldenstrom's, that will change significantly. But as yet, we're not in a rush to treat for those reasons. Now, who do we want to treat? Basically, whenever it is causing any problems, affecting quality of life or causing damage to the body. And so those will be manifested in the different symptoms that we described, but specifically these ones are the ones that we would be looking for when we would want to consider starting treatment. For anemia, the hemoglobin, which is our marker of anemia, we would want that level under 100. Similar for platelets, under 100. And then if there's other symptoms that showing evidence of organ damage, then we would definitely want to treat. Now, something that was more recently in recent times being considered by the international community of clinicians is that because of the risk of hyperviscosity and the damages from it being particularly high when the IgM gets over 60, even if you don't have any symptoms, we would consider treatment. So what can we actually treat with in the first line setting? Before I get into that, whenever you look at treatments, you'll be thrown a whole lot of different, I guess, terms into trying to explain how effective a treatment is. And I thought I'd just define some of those. So you'll hear the term complete response, which I won't go into too much because there's almost no treatments that give this in Waldenstrom's. But what that means is having a normal IgM level and clearance of the bone marrow from infiltration. Very good partial response, or VGPR, is when that IgM level has dropped 90% from baseline. And so if it was, 50 to start with, it's gone down to 5 or less. And or if the IgM is normal, partial response is between 50 and 90. And then that's meant to say within 25% of baseline is stable disease. So it can either go down 25% or up 25%, it's stable. But once it goes over 25% and increase of the IgM from the lowest level, then that would be considered progression. The other way your condition would be considered progression is if the other features of the condition are progressing. So if you're getting worsening anemia or getting bigger lymph glands, those will be signs of Waldenstrom's progressing. And then you hear the term PFS, or progression-free survival, mentioned a lot in this talk as well. And that's when the treatment, the time from when the treatment started or when you were registered on a clinical trial, and to either disease progression or death from any cause. And that's important to remember. Death from any cause is also added in there. So how to decide between the different treatment options? Well, if the disease is progressing quickly, we would pick a treatment that acts quicker. Depending on the fitness and the age of the patient, certain treatments are more heavy duty, and or we may be thinking of saving gentler treatments for later if they're younger. And then, of course, probably the most important thing for Australians is what is actually available in a funded way on the by the healthcare system. These treatments are very expensive, and so being able to buy them on your own makes it being able to fund it yourself privately is extremely difficult. And then, of course, we decide based on the effectiveness of the treatment, the specific toxicities, the impact the treatment itself will have on quality of life. There are treatments that are continuous, so you have to keep taking them forever, as long as they're working. Or there are the more traditional, older treatments that have, about 6 months of treatment and then there's no more treatment. And then we also have to factor in the risk of severe infections like COVID and other things. Now, it's fantastic that over the last 20 years, lymphoma research has really exploded, and it's moving away the treatment paradigm from chemotherapy to smarter targeted therapies. And just to list a few examples, this isn't an exhaustive list. We have things called antibody therapies, which IgM is a type of antibody. These are immune proteins that are manufactured in a laboratory that will target those B cells, which are so CD20 is a protein on B cells and on Waldenstrom cells. CD19 is also on Waldenstrom cells, and so these antibodies will target the Waldenstrom cells, unfortunately, as well as normal immune cells, normal B cells, which can cause infective complications. we also have seen a whole range of different enzyme inhibitors or small molecule inhibitors that target enzymes that are particularly regulated in Waldenstrom's and other lymphomas, B-cell lymphomas. So these are the Bruton tyrosine kinase inhibitors, which sure many of you would have heard of. The most studied ones are the three listed there. There's a new BTK inhibitors on the block called non-covalent, which I'll touch on later. And then there are other inhibitors. Probably one of the more famous ones is venetoclax because of its effectiveness in other conditions, it's called a BCL2 inhibitor, which is B-cell lymphoma 2 protein. Then more recently, there's been the advent of cellular therapy, particularly in leukemias and more aggressive lymphomas, and they've been showing significant promise. And there's already been a few patients with WM treated with these in the context of clinical trials. And so they're an exciting new development as well. So what is actually available in Australia for our patients today and facing you guys? Well, first and foremost, I think it's very important to mention clinical trials because it's such a rare condition and we don't, as a result, have the ability to generate robust data very quickly in terms of recruiting large number of patients to trials. It's important to support these clinical trials wherever possible. Now, there's two main categories of treatment in Australia that's available: chemoimmunotherapy, which is a combination of chemotherapy and immunotherapy, which are therapies that are like the antibody therapies. They mimic or use the immune system to do the cancer cell killing. And the most common two that are used in Australia are bendamustine rituximab and dexamethasone rituximab cyclophosphamide. I'll refer to these as BR and DRC. The other one is Bruton tyrosine kinase inhibitors, which are not chemotherapy. They target the enzyme BTK within the B cells. This is a continuous therapy. Now, in frontline, there is zanubrutinib available to patients if they're not suitable for either of these two treatments, which means that it's actually quite difficult to get because most patients would be suitable, even if they're frail, for DRC. It's quite a gentle treatment. Ibrutinib, unfortunately, is not available in any line currently funded by the PBS in Australia. So I thought, well, given that these are our main three options, let's compare them. And so looking at these three treatments, the chemoimmunotherapies are 6 cycles lasting between 5 and 6 months, whereas the zanubrutinib is ongoing. They have very similar response rates. And to make this, this is from like a 25% improvement of the IgM and above. And so they're very similar. The one downside of DRC is that it's not as quick in terms of getting the IgM level down if that's necessary. And it doesn't seem to be as durable as the other two. So with BR, half of patients will be not showing any signs of progression at 5 to 6 years. And the data is not as mature with zanubrutinib, but with the most recent data presented by Judith at the IWWM 11, which is the International Workshop for Waldenstrom's in Madrid. Last year, she presented data that showed that at 4 years, 71% had not progressed, which is great. It's a fantastic result. So they do have specific toxicities. Zanubrutinib is, while it's not chemotherapy, it still does have toxicities. Infections is quite important in BR. DRC is the most well tolerated. Now, one major issue, the things that differentiate the different treatments is these 3 circles I've already touched on, but BR is only available in Australia in first line. And so that makes it quite important to consider it in the first line setting if it's a suitable treatment. Zanubrutinib is fortunately available in relapse. and DRC is available in any line of therapy. And so question comes, which would you want to use first out of the two best performing treatments, which were BR and zanubrutinib? And so this is data from our own research, which has shown that these aren't direct comparisons. So these weren't randomized controlled trial data. This is just registry data from our patient-derived data registry, Whimsical. And it seems to show that BR is just as effective, if not better, in first line than the Bruton tyrosine kinase inhibitors, but in second line and beyond setting, it's significantly worse than the BTK inhibitors. And so for me, there needs to be a good reason not to use BR first for my patients. Following the first line of treatment, when it comes to what's available in Australia, we're very limited, unfortunately. And so that really makes clinical trial participation of paramount importance. So you can use DRC if you didn't use it the first time. There may be some ways you can get bendamustine rituximab, but if you've had a good response in first line more than 3 years and you haven't used these treatment options, they're very good second line treatment options. Zanubrutinib is the only BTK inhibitor available in Australia, and it's preferred actually by clinicians over ibrutinib because in a head-to-head study comparing the two, it had lower toxicity profile. They were very much equivalent in terms of their response rates. But if you can't do either of the above, and there aren't any available trials, then one option is to review what compassionate access or funding schemes are available, looking at other BTK inhibitors, BCL2 inhibitors, proteasome inhibitors, which I'll talk about briefly, and other novel treatments. But even if those aren't available, unfortunately, we'll have to resort to chemoimmunotherapy options that are used for other non-Hodgkin lymphomas. Now, what else is on the horizon, or what's available around the world in this setting? So, of course, ibrutinib is with or without rituximab, and this has the longest follow-up data, and it has fairly excellent response rates and very good PFS, somewhere around the same mark as bendamustine rituximab. But unfortunately, it has slightly greater toxicity than its cousins, its newer generation ones like acalabrutinib and zanubrutinib, because it's less specific for BTK. Acalabrutinib is also available, but there is this concept of non-covalent BTK inhibitors, which are drugs that have designed to be less resistant, to be less affected by resistance of the WM to BTK inhibitors. And in studies looking at these, they've had reasonable responses to those who've progressed on ibrutinib. Now, there's a whole class of things called proteasome inhibitors. These are almost like chemotherapy in that they're not specific to just the lymphoma cells. And they're usually used but they're very well tolerated, and they're usually used in combination with dexamethasone and rituximab. They have excellent response rates of 85 to 90%, but the durability in terms of the progression-free survival is slightly less than bendamustine rituximab. It's more in the equivalency of DRC. And then one of the newer kids on the block is venetoclax, a BCL2 inhibitor. For patients who have progressed on BTK inhibitors, they're still getting 75% response rates, which is excellent in this difficult to treat patient population. But data seems to suggest it would be best used in combination with another treatment. But unfortunately, a study using it with ibrutinib had to be stopped early because they had heart complications. Some practical advice. Fatigue is a major issue, as I'm sure you're all aware. But WM may not be the only reason for it, and so it's important to look for other causes and treat those. Exercise has been proven to help, and often with the support of physiotherapy. And this isn't just walking, it's moderate intensity and muscle strengthening exercises that are important to really make a difference. And another thing that's quite important, particularly in this digital age, is correcting sleep hygiene and trying to avoid electronic devices 1 hour before sleep, avoiding stimulants, and avoiding long naps during the day. One other thing that's very important and practical is that because of a hormone produced by the Waldenstrom cells, iron that's taken in through the food or supplements is very poorly absorbed. And so you're often getting iron deficiency, even though your iron stores may look normal on blood test. This picture is showing cells that need to be looking more red, looking a bit pale, as being iron deficient. And so it's particularly important that if you start treatment, but your iron stores are reduced, then you won't be able to correct your anemia. You won't really get a good increase in your hemoglobin. So it's quite important to get intravenous iron treatment if you are iron deficient before starting treatment for Waldenstrom's. So how can we drive Waldenstrom's forward together? Now, I guess the key thing is, the quick question is, why are there so few treatments available in Australia? I'm sure this is a question on many of your minds. And as I said, it can be very expensive, these treatments. And the reason for that is that to develop a new drug, it takes a lot of people over a long time to get the data required to prove that it works. And so it's a quite expensive process that makes treatment very expensive. And to justify spending taxpayer money on these expensive treatments, governments need robust data. And unfortunately, in rare diseases, it's difficult to get that robust data. So I thought I'd just quickly talk about how we actually can generate data to know if a treatment works. So what typically happens for a drug to become available is it has to go through the different stages of clinical trials. And that will first start in the preclinical stage, which can take several years, where they test it on cells in the lab, or they test it in animal models like mice. And then when they find something that seems to be working in cells and animals, they'll have to try it in humans. And so they first need to establish that it's safe in humans. And so they try it in a small number of patients, tens of patients, and that's called a phase 1 trial to assess the appropriate dose and safety. They'll need to then do a phase 2 study, which is a more expanded study to prove its safety. But what's critical to then demonstrate whether it works or not is the phase 3 study. And you might have seen these numbers I put here. These usually need about tens of patients, hundreds of patients for a good phase 3 study to prove something beyond doubt. Like they use in heart disease studies, you'll need thousands of patients. And all of this can take several years to happen. Usually a phase 3 study is comparing the best current treatment versus the new treatment that's being tested, and usually done in a randomized fashion. So that's what's called a randomized controlled trial. Now, with this very rare incidence of WM, unfortunately, in the last 20 years, we've only seen 7 published phase 3 clinical trials. And they've all totaled up. If you add them all up together, it's only 905 patients. So you can see why we're struggling to have the government fund new treatments, because they traditionally waited for these phase 3 trials to prove a treatment is worthwhile. Now, good or bad, you can see that there are 3 active phase 3 trials in Waldenstrom's being conducted currently. There are many others that are for other B-cell lymphomas that will allow Waldenstrom's patients to be recruited. There are about 100 active trials registered on clinicaltrials.gov. which will allow the recruitment of Waldenstrom patients. So there's significant improvement in this, but we still have a major problem. And as a comparison, there's, instead of just 3, there's 376 phase 3 registered trials for breast cancer. So you can see the problem facing WM. And so how can we generate more data in rare conditions like WM? Well, obviously, first things first, we need to join clinical trials wherever possible. We also need to learn from each other's experiences. As long as we share them, we can do that. And that's making sure that we're connected. And things like these communities like Lymphoma Australia, WM Aussies, IWMF, they help connect patients. But to put it in a more scientific, rigorous way, kind of need a registry that will capture very specific data points, and hospital-based registries are excellent ways of doing this, but unfortunately they're limited by the high cost and workload. And so a lot of these don't actually expand as well as they could, but this is continuously improving. Now, how can we have a registry that is globally reaching and feasible and sustainable? And that's going straight to the primary source of data, you, the patient. This concept led one of the amazing WM patients I've come across, Andrew Warden, who pitched the idea to us to have the whimsical registry, which is a specific registry for Waldenstrom's patients entering their clinical data to help expand the knowledge of WM. This will allow patients from all around the world to provide their data in a confidential manner to support WM research. Now, the study is called Whimsical, and its aim is to increase the knowledge of how WM presents and the different outcomes of treatments. It allows us to look at patient-reported outcomes like quality of life and how the different treatments affect that. And it also provides us ways of generating hypotheses to advance WM research and facilitate patient preference research. Now, how it works is that it's driven by a partnership of patients, particularly the IWMF and its affiliates, with an international group of WM clinicians led by myself and Judith Trotman. And they do recruitment of patients to this study through social media. Patients go online at www.cartwheel.org, which is an ethically approved questionnaire that has been amended to have WM-specific questions. And then once a patient from anywhere in the world goes online and completes a consent form online, they can enter in their critical data that helps. This data is collected and stored on highly secure servers to maintain confidentiality. Now, a lot of people think, well, it's just patient data, patient-derived data. Both clinicians and patients think this. They don't see the value in it. They think it'll be dismissed. But contrary to that belief, there's been significant impact from patient-shared data. We've published in a very high-impact, important journal in hematology, the American Journal of Hematology, the findings from this. Together with me, we have Andrew Warden and 3 other patient representatives on this list of authors. The findings have been presented at now 8 international conferences, the last of which was actually invited by the International Expert Committee. And most importantly for you guys, our data was used in the successful application to fund zanubrutinib in Australia. And so I think I can't emphasize enough how powerful patient-derived data can be when everyone works together. And just to give you a snapshot of what this study is doing and where it's up to, we have over 650 patients from 21 countries around the world who have shared their data. And we can see the importance of the IWMF and their recruitment campaigns causing big boosts to recruitment. That data I presented earlier, comparing bendamustine rituximab to the BTK inhibitors, that gave us important information as to how to sequence these treatments, was generated by this data. And other things that, clinical trials and other registries haven't been able to find is that we've found that up to 10% of patients are demonstrating symptoms consistent with PTSD, which is something that was a complete surprise to us. And we were able to demonstrate that patients on BTK inhibitors were reporting better quality of life, which is just demonstrated on this graph here on the right. Okay, I'm going to wrap up because it's been a long talk so far. Where are we going to with WM research? I won't go through this whole list, but needless to say that there are a lot of new treatments coming to WM, lots of active trials currently. And the ones that I've put in red are the ones that are trials being run in one of the sites of the trial is in Australia. So it's treatments that are available in Australia, which is fantastic. So we have a lot of different options being made available through these clinical trials. An amazing development in the world of lymphoma has been the bispecific T-cell engagers, or the BiTE treatments, which use antibodies to drag your T-cells, your immune system cells, the T-cells, to go and attack the cancer cells. And 2 of these are being trialed, available to WM patients in Australia. There's also cellular therapies, one of which is available in Australia. And then there is a whole range of different, completely new ways of treating lymphoma and Waldenstrom's that are being trialed, 2 of which I've listed here, are available in Australia. So putting it all together and to conclude, WM is rare, but you are not alone. And together you have a very powerful voice. It's a slowly progressing condition. And as a result, there's no rush to treat with all the toxicities of treatment that there are. There are relatively limited treatment options due to its rarity. And so clinical trial participation is crucial. But we have been very fortunate to see a massive increase in research in WM. And for a rare condition, it's punching well above its weight in that regard. And if you want to contribute to driving the research forward, you can directly contribute to the Whimsical Registry by registering at the website listed there, www.cartwheel.org, and there's more information available at that link. And with that, I'll take questions. Oof, sorry, it was very long.
Thank you so much, Ibrahim. I really appreciated that, and I'm sure everyone in the audience really appreciated it as well too. We've already got some questions coming through. I can see Judith is popping in some comments in the chat as well too about clinical trials that are available in New South Wales as well. So while we're waiting for more questions, so if anyone does have any questions, pop them in the Q&A function and we'll get to them as well too. I wanted to ask a question. Yeah, that's fine. Yeah. I wanted to ask a quick question that is probably relevant to anyone who's currently on treatment as well too. When they finish treatment, what is the standard follow-up schedule that you would expect for a patient to then come through as well too? It's probably a very difficult question to answer, but it's a question that we actually get asked quite a lot through our nurse hotline, and people are always a little bit uncertain in this phase as well too.
Yeah, so I mean, like most things, there's no one size fits all approach. Every patient journey will be different, how they've responded to the treatment initially, the complications they've had, the complications of the disease they've had. All of these will dictate how frequently they need to be seen. In the most common situation where usually our treatments are effective and we see a significant improvement in symptoms, frequently you'll have, for the first 12 months, you'll have, either every 3 months review, stretched out to 6 months, and then stretched out to annual, going out to a few years from treatment. But again, I have to reiterate, it's a case by case.
Yeah. And follow-up tests at those appointments as well?
Yeah, so usually it all depends on how it first presented, but the ones that have to be done would be the IgM and the hemoglobin, and a full blood count to look at the other cells as well. And then I would normally have a check of the liver and the kidneys as well to make sure that there aren't other ways that the Waldenstrom's is either causing damage, or that there's damage from the treatment, or those sorts of things.
Judith, did
Can
you
I
have something to
make
add?
a comment there? I agree with Ibrahim. It's no one size fits all in terms of follow-up after treatment. If you start and think conventionally in terms of follow-up after conventional rituximab chemotherapy, you know, you'll often see a patient 1 month after their last treatment because, you know, they sort of come through the wars and they, you know, want to sort of chat with you about, you know, the side effects of therapy and what their, you know, what the expectations are in terms of the tempo of recovery from any toxicity of the therapy. But then ultimately you're wanting to stretch that out to a 3-monthly, and then, as Ibrahim says, maybe then a 4-monthly and then a 6-monthly follow-up. And it's about the tempo of that individual patient's disease, how often you will follow up, and about their relationship and access to their GP and their GP's comfort and their own comfort with monitoring their own hemoglobin and IgM levels, if they've been the drivers for therapy as opposed to various immune manifestations of their disease. So there is no one size fits all, but very often patients will be as low as 6-monthly. Often patients in clinical trials, the quid pro quo for participating in the trial is that they are then locked into a 3-monthly follow-up or 12-weekly follow-up. For patients who've been on oral therapies in clinical trials like zanubrutinib or ibrutinib, they need obviously to continue on those therapies. Those therapies are just a switch for the lymphoma. And as soon as you stop it, the lymphoma will come back again. So they need continuous drug dispensation, and that's never done in the context of a clinical trial any less frequently than every 12 weeks. But on PBS, when you get zanubrutinib, you're given a prescription and you can get 1 month supply at a time. That'll probably go out to 2 months, as we know, in the 1st of September. But how often your IgM and hemoglobin should be being checked very much depends on, you know, your response to therapy. And it's something that you work out and that you're comfortable with working out in conjunction with your GP, because with your hematologist, because in the end, if we don't need to do anyone's hemoglobin or IgM, all right, it's more patients tend to want to, you know, do it more than we want to do it. In the end, we don't want to be treating patients until they start risking threats of symptoms. So it's, you know, it's about how much mapping you want to do. The other little thing is that when you're on zanubrutinib, you can sometimes get neutropenia, low neutrophil counts. So we do need to check in on how people's neutrophils are coping with the zanubrutinib when they first start that. But I've got to say, zanubrutinib is about as close as you can get. And don't quote me on this because I'll sound very heretic. So no one's allowed to quote me on social media, but it's about as close as you can get to a set and forget type of drug. And I know that many people online, I can recognize a few names that I suspect are patients who have been on zanubrutinib, or I know have been on zanubrutinib, and know that it's extremely well tolerated. Yeah.
Just to add to that, is that bone marrow biopsies are not routinely done for monitoring. Usually you'd only do it in the context of a clinical trial, or if there's a particular concern prior to starting the next line of treatment, they would do a bone marrow biopsy.
Yeah, maybe we could just discuss some of the comments here on the line, and I want to bring up. I've got a few experts online. There's a lot of patients here. You know, if your name's Leah, Dave, Kathy, or David, or Glenn, you probably know more about Waldenstrom's than I do. And Glenn has pulled you up a bit there, and I did when you were speaking to him, I thought, oh, someone's going to bring this up, and sure enough, Glenn has.
What is that?
By what you mean, what WM is not inherited, but there is increased risk of developing WM if it's in the family. Do you want me to explain the stats there, or do you want to?
I can do it. So I wasn't clear about something I'm sure was important to people. So a lot of people are concerned that this is like, you know, a classical inherited condition like cystic fibrosis or something, where there's like a 25% chance or a 50% chance of passing this on to your kids. And that's absolutely not the case with Waldenstrom's. It's something that develops later in life by chance. And we still don't know exactly what causes it. But what has been noticed when they do large studies, observational studies of WM patients, is that if you have a family member who has had Waldenstrom's or another lymphoma, then your risk of Waldenstrom's increases almost 20-fold. Now that sounds like a lot, but if you remember your absolute risk is 3 per million per year, that's going to 60 per million per year. So it's still a very low risk of developing Waldenstrom's, which is why I put the term slightly increased risk, because while in relative numbers it seems huge, 20-fold increase, it's actually the absolute increase is very small. You know, you're going from 0.001% to 0.002%.
Yeah, and that increase covers not just getting Waldenstrom's, but also getting a monoclonal gammopathy of uncertain significance, a sort of a precursor to Waldenstrom's or another, lymphoproliferative disorders. So yeah, it's something that we really only do testing when there's a clear familial association. And so we do always ask about family history.
Yeah.
And then I think it's important that we talk with children of, I've had patients who say their parents have also had Waldenstrom's or another lymphoproliferative disorder. And then we talk to their children as they become adults about whether or not they want to be tested, rather than automatically going and doing these tests. Shall we just, I'm mindful of the time. So I might just whip through a couple of the questions that I can answer. IgM is a pentamer, so it's a very big immunoglobulin, and it's a very viscous. Julian, your biochemistry might be better than me. I'm not quite sure what a cyclopentene is. Presumably that means a circle pentamer. But Ibrahim might be able to answer that better.
No, I'm not sure. I'm not sure. Terminology.
And likewise, your question about computer modeling is a bit beyond me. We certainly don't have, I don't think, very good cell lines for WM research, do we, Ibrahim?
Not that I'm aware of.
Yeah. Now, we talk about IgM. There's lots of research done on IgG paraproteins, but they are usually associated, well, they almost invariably associated with either lymphoma or myeloma. The couple of really important questions there. Some of them have all suddenly disappeared, and some of them I thought were really important. David's asked a question that's sort of like a WM, not 101, but WM 105 question, and something that I think is important to inform you guys. And thank you for asking this, David Young, as WM Aussie's lead. There is an issue right at the moment in terms of accessing the non-covalent BTK inhibitors. So for patients who have had zanubrutinib, ibrutinib, or acalabrutinib, and generally in Australia, it's only zanubrutinib, that is a covalent BTK inhibitor. Now, the non-covalent BTK inhibitor that exists in Australia is called pirtobrutinib, and it is possible in the talk chat, in the chat rooms or whatever, you've heard about patients who've had pirtobrutinib. And this is a very effective BTK inhibitor that has shown great promise and durability in treating patients with WM. However, there has been a 4-fold demand beyond what was expected globally in the pirtobrutinib compassionate access programs, and so they have all shut down just in the last week globally. And we've been desperately trying to get our hands on it for a couple of patients, and we've been told no. So that's a rather distressing situation to be in, and we have no visibility from the company, Eli Lilly, as to when that will happen. And so it would be good, David, if you and IWMF could get in on the bandwagon and, ask for some clarity. I think there's always dangers to these compassionate access programs. that if they're really good, you'll get lots of people staying on drugs for a lot longer, and you'll have a lot more people going on drug, and then you end up with big supply chain issues. And that really becomes an issue, quite aside from the commercial issues that are always associated with those sorts of programs. But there are a number of clinical trials of other treatments. The trials that we've got here at Concord include things like the Clover study, which is a really interesting study. And we've certainly seen some good responses with that radioimmunoconjugate drug. And then there are the bispecific antibody studies where Waldenstrom's patients are sometimes included in some of those clinical trials, as well as the PROTAC study, a BCL2, I think it's a B-cell. I don't think it's, I've pasted this in here from my fellow, but I actually think it's a BTK protein degrader, not a BCL2. So please, someone don't cut and paste and forward that what I've got there in the chat there, because that would be very unfortunate. And I think it's the study number is a bit wrong too. But there are other mechanisms of action, other oral therapies that we could potentially get to. I think the important thing is just ask your hematologist, would you potentially be eligible for any clinical trials? Because there are a number of promising new therapies, but it gets pretty complicated because trials open and close very quickly. The other complicating factor is that venetoclax is no longer available on compassionate access program from AbbVie either for patients with WM. So, you know, that may interest people in the Beijing BCL2 inhibitor study, which can also include patients with WM. So there, you know, there are options out there, but you know, you do need to speak with your treating hematologist. I'm absolutely delighted by the comment from Tracy saying this is the most informative and important presentation she's ever seen. That means that you're doing this presentation forever and a day now. And I tell you what, did you notice, everyone? Did you notice, David? The slides are a lot flossier up now. Now they're much better now. What else have we got there? Patients who are unsuitable for chemoimmunotherapy in the first line. Well, there is definitely not a standardized approach, Shri. And if you come to some hematologists, they have a very low threshold for saying patients are not suitable for chemoimmunotherapy and giving someone a BTK inhibitor. I think that's the wrong thing to do. I think that's a disservice to patients in the long term. Because while I like bendamustine and rituximab as much as Ibrahim does, I also am nervous about it. And I think there are a number of my patients who I will offer dexamethasone, rituximab, and cyclophosphamide to sort of kick the can down the road for another 5 years before they need treatment again, and then put them on a BTK inhibitor. Because dexamethasone, rituximab, and cyclophosphamide is, you know, it probably doesn't have the same durability of response, but it is gentler than bendamustine, and is not 6 months of therapy, and probably not as immune suppressive. And, you know, there are other little things that make me think, well, if someone is chemotherapy eligible, but still a bit frail, start gently with DRC and save the BTK inhibitor for later, because we still also don't have a good picture as to how people go on chemoimmunotherapy after BTK inhibitors. We're assuming, and we have no scientific rationale for why they wouldn't go well, but we actually don't know. No one's actually published that. And a BTK inhibitor is something you have to keep taking every day. And then when you have to stop it to get your skin cancer removed or your hip joint replacement done, you know,
vaccine
patients have terrible reactions. That's a segue to talking about vaccination. All right, we have shown in our Tribeca study, which has just been accepted for publication by the European Journal of Hematology, and that was a huge collaboration with patients on zanubrutinib and ibrutinib. 9 of whom wanted to stop their BTK inhibitor to get their 3rd COVID vaccination, and 9 or 10 who said, no, thanks, we'll just get our vaccination and keep on the BTK inhibitor. Stop the BTK inhibitor, you definitely get a better anti-COVID, anti-spike antibody response if you pause your BTK inhibitor. Problem is, once you start the BTK inhibitor again, that antibody response drops down again. Now, we don't know whether a little response persists, and a little response is better than no response, but it's definitely something I would not advise anyone tried this at home. They should, if they're seriously considering stopping their BTK inhibitor, they need to have a chat with their hematologist, and it should only be considered a pause in the context of vaccine. And if you are going to do it, you've got to give yourself 3 days or so to clear the BTK inhibitor from your body before you actually had your, what would now be your hopefully your 5th vaccine. One thing we did find in our COVAX and lymphoma study, and that was receive funding support from Lymphoma Australia. They were so quick and agile in the height of COVID pandemic in 2021 to say, yes, we will give you some money and we'll help you get the study up and running. While the B-cell response to vaccination is impaired in patients after chemo and immunotherapy and after while on BTK inhibitors, their T-cell response is not bad. And that was quite encouraging and reassuring, because I, in a simplistic way, think of your B-cell response as helping you, stopping you from getting COVID, whereas your T-cell response is very much related to how well you cope with COVID when you get it. If you get COVID and you're on a BTK inhibitor, if you get COVID and you're on zanubrutinib, you need to cut your zanubrutinib dose down from 4 capsules a day to 1 capsule a day while you're on Paxlovid, because the Paxlovid will greatly increase the levels of the zanubrutinib in your bloodstream. And we don't want to create any problems. So sorry, that was a bit of a run through based on a few questions, but it's sort of like FAQs that I always get asked in clinics, so hopefully that might reduce that number. Kathy says, I presume you've been cryo. Kathy, I think if you have Waldenstrom's and you have a cryoglobulinemia, it's very likely to be caused by your Waldenstrom's, by the same clone that is causing the Waldenstrom's is causing this cryoglobulin.
I actually think she means central retinal vein occlusion.
Oh, well, that's a hard one. I would say no. Yeah, well done, Kathy. Well done, Ibrahim. Yeah, retinal vein occlusion. You're the expert to answer that.
So look, most cancers do have an increased risk of blood clotting. Waldenstrom's isn't immune, but it's relatively small, and in fact more bleeding is seen with Waldenstrom's due to the hyperviscosity. So it's really difficult to know, but there is a slightly increased risk of clots with WM, and I think it's hard to give a definitive causation, but it may have played a role in that.
Les has asked a comment about, can you be suitable for trials if you have various autoimmune conditions? And the answer is sort of yes and no. It depends on what autoimmune condition, whether it's driving, whether it's been driven by the WM, and also there are some, the answer is probably yes, but not 100% yes.
Yeah, and also if they're causing significant impairment of your kidneys or liver, then that would preclude you from being able to go on many trials.
Julian, the bottom answer, you should never trust a doctor who says, yes, Evershield's ineffective, because there might be some minor effects, but basically I think we're not running to give Evershield to our patients now because it has really lost its efficacy. And also we've got, better treatments with Paxlovid. Paxlovid is definitely the COVID viral treatment of choice, but you need to talk to your doctor about possible drug interactions when you're on Paxlovid, because it's not only zanubrutinib, but other medications that can have drug interactions. But it's all easily managed. You know, most people can stop whatever other drug they're on for the 5 days plus another 2 days for clearance of the Paxlovid while they're taking Paxlovid. And the most important thing is to get good control of the COVID. How effective is the T-well? How long is a piece of string, David? It's very effective, shall I say that? But we certainly are seeing nice T-cell responses, and we're pushing our colleagues at the Kirby to publish their T-cell data a bit more, but we were quite reassured. Yeah.
I think the feel at the IWWM was that post the vaccine push in WM patients, there's been a lot lower mortality rates seen. I mean, there's no way to prove direct evidence that the vaccines have prevented deaths because of the numbers being small, but certainly in the 2 eras, pre-vaccine and post-vaccine, the mortality in WM patients has dropped.
Yeah, and I think also, oh God, there was something that went straight out of my mind about T-cell vaccines. Can't remember it now. It might come back. Yeah. Looks like we've answered them all. There's no other questions. We've exhausted you all, have we?
It was a long time.
Judith, you made my job very easy. I haven't even had to ask you any questions.
Oh, we
listening.
always get a wonderful set of questions from our WM colleagues. It's just fantastic. Yeah. And I say colleagues because we do consider each one of you, we hope, is on whimsical and is our partner in our research. Yeah. Because it's quite cool, you know, coming from Australia and taking on the world and building this global, you know, this global database that Ibrahim has built, and he hasn't even launched into how we hope to use it as a template for so many, you know, quality of life surveys and the discrete choice experiments over treatment priorities. So you know, there's huge potential. There's certainly huge potential for getting whimsical much better, you know, more Rolls-Royce version of whimsical, but you know, it does the job and it's what we can afford, and you know, it's got us started. Yeah. Can't remember what I was going to say about vaccines, but definitely at IWWM we were very encouraged by the how well everyone was coping with their COVID now. You know, I don't think you should be living in fear anymore. Right? I don't think you should be sitting in the middle of a church singing, you know, with a big choir going full bore. I would prefer you sat. I tell my patients who go to church, sit out in the foyer, all right, in the cold, windy foyer. And I'm not a fan of movie theatres as well, but otherwise you should be out, and you should be rugged up and out there walking, hitting the streets anyway, and pushing your body a little bit, because you've got to push through the fatigue a bit. And I don't, you know, I don't say that flippantly. We all recognise the pervasive effect that fatigue has on the quality of life of patients with Waldenstrom's.
Absolutely. I think that's it. I think all that's coming through now is compliments for you both. So I
we must look at those before we leave, Ibrahim. We like that.
No, there was one more question.
Have I missed? Oh yeah, there is another question come through. Yeah, okay. Should WM patients continue to have COVID vaccine boosters every 6 months, no matter how many they have had?
Yeah.
Judith is doing a big nod.
COVID's still a you know, a really bad viral infection for lots of people that makes you feel wiped out, and you don't want to be feeling wiped out. You know, you want to live your life to its fullest, and so I reckon you should be getting vaccinated every 6 months.
But we don't know if it's going to stay every 6 months or if the recommendations will stretch out to like an annual thing like the flu shot. It's continue to watch this space, but ongoing vaccines are almost certainly going to be in the near future.
And I get a sense, and you know, look, we just, you guys are probably keeping up with the whole COVID space faster than we are. You know, but I do get the sense that so long as we stick with Omicron subvariants, we're all okay. Once we get a new variant, that's when you might need to sort of hunker down and protect yourself a little bit more until we know, how the variant is spreading and how much morbidity and mortality it's causing within the general community. But I think, now is the time to get out there and live your life as much as you can. And get your flu vax. Oh, and this is another great thing for you guys. Shingrix. I might be wrong, all right, but I think it's coming on the PBS on the 1st of July. And if you could find that out, Erica, that would be really good, because I think Lymphoma Australia should be making it clear to patients. It costs you $250 a dose, and you've got to get 2 doses, like 3 months apart. And it's a very effective shingles vaccine. But I've heard word it's coming on the PBS, and I think that means it's the 1st of July, but I'm not sure. So
I can have a look for some information. If I find anything, I'll circulate it out with the webinar link after this as well too. Sounds great. All right.
And the flu vax. Get the flu vax.
There you go. There's some time.
And get your partners to get the flu vax. That's the other thing. Think about your partners, your children. They need to get their vaccinations.
Yeah, and do that shield around you again as well to apply those same principles as COVID. Yeah. All right. Well, we might wrap up then if there's nothing else. It's just more compliments coming through saying you guys are all amazing. So
Thanks very much, everyone.
And thank you all, everyone, for coming tonight. If you do have a couple of minutes afterwards, just click on the survey link and complete it. It helps us and guides us further with further information and education going forwards. Okay. So thanks, everyone, and have a fabulous night.
Thanks, guys. See you later. Go and update your whimsical profile. Okay. Even if you just enter and change one full stop, Ibrahim then recognizes that you're in and you've got extra long-term follow-up.
Yep.
Okay.
Thanks,
Bye.
everyone.